Welcome to the 98th session of the weekly huddle. My name is Anoop and joining me today is my friend and co-host Praneeth. We both are cardiologists working at care hospitals. You all are quite familiar with the huddle format, so I'll skip the introduction. Today's case is a very routine case for a cardiology practice, and I have tried to combine a few items that we should discuss. Because in our clinical practice also, the patients don't present to us in isolation. They always present to us with a variety of clinical factors that we need to take into account before we make a final common decision. So this is the patient which I saw 3 weeks back in my OPD. And I'll just run you through the case because this is going to be a case discussion. If you have any questions about or queries about the patient's clinical case, you can address that to me directly. So this is a 55-year-old guy who actually was admitted on my on-call day with symptoms and signs that were suggestive of acute decompensated heart failure. This patient is actually a resident of a small town about 150 kilometers away from Hyderabad, and he's visiting his family member here, essentially his son. And during his visit, he has not been very compliant with his medications. And even at home, we are doubtful about his compliance. This time, his son pretty much took the charge of his health and brought him to the hospital. In the hospital, he had all the features of heart failure decompensation, which was managed with routine medications, including diuretics and non-invasive positive pressure ventilation. He responded quite well. His ECG was suggestive of old anterior wall MI. Echocardiogram suggested a 30% ejection fraction with akinesia involving the anterior wall. Although his troponin was negative, we did do an angiogram at that time to ascertain if there is any unrevascularized territory that we need to fix. The angiogram suggested that the stent which was placed in the LED was patent, although the rest of the LED was diffusely diseased. RCA had a CTO, essentially meaning that it was occluded chronically. Circumflex was fine, and there were left to right collaterals which were going across. He was suggested to be on medical management for coronary artery disease, and that was continued as such. Over the time, the only complicating factor with his treatment was that his blood pressure was always on the lower side. It was always in 90s to low hundreds. It never exceeded 110 as to speak. So we were a bit cautious about putting him on heart failure regimen. Because early on we had to give him a lot of diuretics, we anyway were not quite aggressive with the heart failure regimen at that time. So essentially he was discharged on dual antiplatelet therapy, which he was already on. We thought of coming back to single antiplatelet. His stent was placed more than 4 years ago, although we don't have details of that stent. But for now we continued on dual antiplatelet. He was on a high dose statin that was maintained. The only drug that we started on for heart failure was beta blocker, and we put him on metoprolol succinate 25 milligrams twice daily. He was requiring some diuretic even at the time of discharge that we continued, and he was on some other miscellaneous drugs like PPIs, antibiotics, and whatnot. He's non-diabetic. He had been previous smoker, but he had quit smoking after his MI about 4 or 5 years ago, and since then he has, at least he says, he has not been smoking. He actually came to my OPD after 1 week of discharge, and in the OPD, other than non-specific weakness and fatigue, he didn't have any other specific complaints. Of course, his physical activity was limited because of recent illness. His blood pressure in the OPD was 102/74 with a heart rate of 82. His rest of the examination was more or less okay. He still had some edema on his leg, but I couldn't appreciate significant jugular venous distension, and his lungs were clear. His echocardiogram I did not repeat. I'm just reiterating the echo that was done in the hospital, which was ejection fraction of 30%. He did have moderate mitral regurgitation. The rest of the right side was okay. His RVSP could not be accurately calculated because his TR was kind of mildish, and we could not get a very good envelope when we were assessing the tricuspid regurgitation. So this is the overall background of this patient. I'm just going to put up the discussion points about the medical therapy for this case, and then I'll ask Praneeth for his opinion, and then we'll go across. So this patient is in OPD now. We have to aggressively manage his heart failure regimen, understanding that we don't have a lot of blood pressure room to work with, and he is in ejection fraction range where there is a very high risk of him decompensating. I didn't tell you all the other lab parameters just because I wanted to restrict the discussion to this. His rest of the parameters were okay, particularly hemoglobin, thyroid. We did check his vitamins, they were okay. His renal function was fine. LFTs were checked while he was admitted, that was also okay. During this admission, the only thing that we checked was his renal parameter, and those were fine as well. Santosh asked the question about his ECG. So his ECG was sinus rhythm. Heart rates were recorded mostly in 70s to 80s. I don't explicitly remember his PR intervals or QRS durations, but they were within normal limits. The only thing which was present was the QS pattern from Q1 from V1 to almost V6. If I vaguely remember, his QRS duration was narrow. So the discussion points for this patient is how to guide our patients for fluid and salt restriction, which I'm sure all of us are going to advise him to restrict their salt and water intake. In this weather, particularly in Hyderabad and a majority of the part of India currently, the heat wave is kind of making everybody's life miserable. So how do we advise our patients in terms of restricting the salt and water, understanding that it is very easy in this heat to become dehydrated? Second is the role of SGLT2 inhibitors in such patients who do not have diabetes. Do we have enough confidence that we can start SGLT2 inhibitors in these patient subset, understanding that there isn't much hemodynamic price to pay when we put SGLT2 inhibitors as compared to we give traditional heart failure therapy, where blood pressure tends to drop a little bit. The third discussion point is what is our overall practice? Are we starting ARNI directly, or we are first testing a patient with ACE inhibitors or ARB and then start them on ARNI? I know the data kind of supports using ARNI as the starting therapy, but in this kind of subset with blood pressure not having that much room, how comfortable we are starting that? And then the last but not the least, how to select patients for prophylactic ICT. If you go by the ACC guideline, this patient does meet the criteria for prophylactic ICT, but we do understand that prophylactic ICT comes with its own price. And in the Indian subset where prophylactic therapy, particularly if it is a high cost therapy, may be a little bit difficult for us to advocate to our patients. So with this background, I'll open it for discussion. I'll ask Praneeth for his opinion, and then I will ask my cardiology colleagues how they would manage this patient, and we'll go from there. So Praneeth, what is your take on this patient?
Yeah, good evening, Anoop. I had a similar case seen last week. So based on those experiences, equally today's case, I'll try to tell me my take on this case, or particularly cases like these in particular. So basically, a coronary artery disease, Atrial MI, infarcted with severe LV dysfunction, infarcted Agrawal did delayed revascularization, but with he essentially has residual LV dysfunction, severe LV dysfunction 30%, with moderate mitral regurgitation, recent admission for heart failure decompensation with fluid overload state, stabilized. Now we are kind of acting or looking at giving him the guideline directed medical therapy for his heart failure with reduced ejection fraction. What we understand now is that patients need to be on the four pillars of heart failure therapy, that is RAS blockade, ACE, ARB, ARNI, beta blockers, carvedilol, metoprolol, bisoprolol, and aldosterone antagonist or mineralocorticoid receptor antagonist, spironolactone or eplerenone, and fourth pillar being the SGLT2 inhibitors, empagliflozin or dapagliflozin. Other drugs have morbidity benefit in terms of improving the quality of life, but these four pillars essentially improve the longevity or the mortality benefit. For coronary artery disease, you already mentioned for secondary prevention, patient of ACVD event, we need to give the patient antiplatelet therapy. Dual antiplatelet therapy may not be adequate for, may not be necessary for this patient, so downgrading to single antiplatelet therapy. Statin, continuing depending on the LDL target, preferably reaching an LDL target of less than 55, and diuretic therapy for decongesting him or making him euvolemic as needed. We give diuretic therapy, most importantly telling the patient, what I do practice is to ask the patient to look at signs of fluid overload, looking at pedal edema, noticing whether he has any congestion or breathlessness. And if possible, I ask patients to get a weighing machine and weigh themselves first thing in the morning after they go to washroom, and weigh themselves and make a daily note of their weight. And if the weight is consistently fine, their volume status is okay, versus giving an additional dose of diuretic if the weight increases. Regarding the fluid restriction, I would ask them to give an arbitrary number of 1 to 1.5 liter a day. And I essentially ask them to trust their thirst mechanism, take sips of water when there is a thirst, and restrict it as much as possible. And in general, I give an arbitrary number of 1 to 1.5 liter a day. Salt restriction is something which I ask that try to limit salt intake as little as possible as per your taste needs. Absolutely avoid added salt in the form of pickles, papads, chutneys, etc. Regarding adding the other guideline directed medical therapy, the patient is already on a beta blocker. He is not on any of the other three drugs that I mentioned. So you try to find every reason or an opportunity to include all these things. SGLT2 inhibitors at this point of time, being borderline hemodynamics or low pressure, so to speak, maybe becomes a safer choice because it does not alter much of the hemodynamics. But with the possibility of dehydration, I would still be not comfortable starting him right at this point of time when his fluid balance seems to be not completely established. So until I'm completely confident that he will not be decompensating again, maybe I will wait for a few more weeks when I think that his volume status is adequate, and then I add SGLT2 inhibitors. Irrespective of the presence of diabetes, can I add SGLT2 inhibitors? With the current evidence which has been there, I'm okay to start SGLT2 inhibitors. So I would start this patient provided I'm okay with his volume status. The other question of, can we directly add ARNI or test with these things? If the patient's pressures were otherwise fine, I would not hesitate starting directly with ARNI. Again, because enough evidence or probably experience, I should say, that you are okay, comfortable starting ARNI. The only challenge that I look into is about the risk of first dose hypotension. If pressures are okay, then I would probably start directly ARNI. In this case, because pressures were not that okay and I still have to give some dose of ARNI, giving them low doses of RAS blockade is possible with either ACE inhibitors or ARBs. So I would start this patient with a low dose of ACE inhibitor, something like 1.25 milligrams of ramipilor or something, to kind of introduce him RAS blockade. That flexibility is not there with ARNI. Provided pressures are fine, maybe I would have considered to directly add ARNI with, as I said, some confidence that I developed over the past few years using these things. And I think the last question that you asked is about ICD. I will share my recent experience with the patient, which I said, where the attendant was quite apprehensive with the risk of future events and whatnot. So I have advised Holter for the patient, a 72-hour Holter, to see for any evidence of any significant arrhythmias. The things that I'm looking at is presence of any non-sustained ventricular tachycardias, and look at any other triggering event, something like frequent ectopics or something. If any of those things are okay, then I would advise. The other thing probably I advise, if the patient is okay, is doing a cardiac MRI, looking at this car burden. If this car burden is again significant, maybe something like 10-15% or more, probably that will be a soft criteria for me to consider, particularly if the patient is okay affording an ICD. And if not, I would be okay continuing the other drugs, because beta blockers per se reduces the chance of arrhythmias. And if there are any things which I can justify myself in recommending ICD, I would recommend ICD for this patient. This is, I think I answered all the questions that you said, Anoop. If there anything, I would probably answer.
So Praneeth, what is this concern of ICD? Like, why are we doing all this exercise rather than simply just saying you need ICD, go for it?
Like for the, at least in Indian context, the way I look at it is about justifying the cost benefit analysis. When ICDs are expensive, yes, they do save lives, provided we select the cases properly, so that we justify. And ICDs cost about 5 lakhs or more, and it is a significant amount for a lot of people. So, and most of the patients, they do take your recommendation seriously, so it becomes a responsibility to advise them properly. And hence the issue of looking into these things and trying to justify a reason.
Okay, perfect. Thank you, Praneeth. I will continue my discussion. I will ask Vijay sir for his opinion. Sir, if these kind of patients come to you, how do you escalate therapy? Do you start everything at the same time? Do you go one step at a time, understanding that the systolic pressure is 100? And what is your tips and tricks about fluid management, understanding that it's the heat outside is quite unprecedented? Vijay sir.
Good evening, everybody. Basically, this patient is having ischemic cardiomyopathy with severe LV dysfunction with EF of 30%. The most common causes are because of the scar related, or it could be due to hibernating myocardium. In this scenario, my sequence of drug, single dose antiplatelets, because patient already had a angioplasty to LAD 4 years back. Beyond 1 year, there is no need. So single antiplatelets, I recommend the second order is atorvastatin 80 milligrams. That is the third thing is I will add beta blocker already, which is taking. Fourth, I will use SGLT2 inhibitors because it will not affect the hemodynamics. And I will wait for 1 or 2 weeks to start straight away ARNI instead of these inhibitors, because their ARNI are more efficacious than ACE inhibitors or ARB. Then I will add aldosterone also in the same sitting. These are the sequence of drugs. Regarding fluid balance, I would recommend 1.5 liters per day, and advise the patient in the summer not to go outside because dehydration. And salt restriction is mostly to 2.3 grams. That is ideal. More than that, we cannot give. And this patient has got recurrent anterior MI, so the fibrous, the scar is definitely high. So the primary prevention of ICD, definitely there is a indication, but the cost, as already mentioned by Dr. Praneeth, the prohibitive cost of it, especially the dual chamber ICD in Indian scenario, that is one of the drawback, and is a candidate for a ICD for primary prevention. And apart this about the medical management, if the patient has got still some angina, I would have advised the revascularization of RCA, which will reduce the MR also. Thank you.
Sir, my question to you is about ARNI. You have got a patient with low EF and heart failure. There is no doubts about the clinical utility of ARNI in such cases. What is the low blood pressure beyond which you feel uncomfortable starting or escalating the dose? And what are your tips and tricks if you have to start these drugs?
I think if it is above 90 also, I will start.
And my guess is your starting dose is 50 milligrams twice daily, right?
Yes.
Okay. Sir, what is your thought process on breaking the 50 milligram into half and giving half tablet twice daily?
That is also that novel concept, but the minimum recommended dose is 50 milligrams BD. So I think it will have only placebo effect.
Okay. Thank you so much, sir. That novel concept, I think that is what I wanted to bring up, because some would think that it may not be novel, but rather a non-scientific concept, because we don't know what is happening to that half tablet. A starting dose, as you mentioned, is established as 50 milligrams. And sometimes it causes very precipitous blood pressure drop, which is what concerns me whenever I put them on these drugs. Anything else, sir, that you would do for this patient other than the discussion points? You did mention about opening up the RCA. That point is well taken. Anything else?
Idea was if you open the RCA, the degree of MR, patient is having moderate MR, the degree of MR also which will come down, and the symptoms of heart failure also will be lessened.
Right, and these are some of the points that I think we discuss in detail whenever we talk about the indications of CTO recanalization, because these kind of cases, they never make it up to the indication because they are very specific about a particular patient. So I think till the time we make sure that we select our patients properly with the best intention of improving clinical outcome, I think CTO recanalization can be justified even in the absence of angina. Sir, thank you for your thoughts. I will move on. I will ask Praveen. Praveen, if you are able to hear me, could you share your thoughts about this case, the discussion points, and how do you manage?
Sir, good evening, everyone. Sir, regarding this case, regarding the salt restriction or the fluid restriction, I would be asking the patient how much, what is the amount of water he will be taking daily, and if he is excessively feeling thirst because of the summer, I would ask him to take the what you call just chew, have a chewing gum or anything, just sips of water rather than that of quenching the whole of the glass. The next would be the reduction of the dosage of the diuretic. And in my follow-up during summer, I would check his diastolic blood pressure. If the diastolic blood pressure is between 60 and 65, and I would change the dosage of diuretic or keep it every alternate day rather than completely stopping it or decreasing the dose. If the patient is kept already on SGLT2 inhibitor, then as it also causes natriuresis, I would decrease the dosage based upon again the diastolic blood pressure. If this patient is having borderline pressure, the giving of ARNI at 50 mg BD as per the recommended dosage, whether the patient is having a drop in pressure or not, I would first initially see what is his response on starting ACE inhibitors and all that, because ACE inhibitors are more prone to cause the precipitous drop in pressure. Then I would switch him on to ARNI to see whether he will be able to tolerate or not. So regarding these, and before going on to CRT or the prophylactic device therapy, I would see whether the patient can be revascularizable or not by doing cardiac MRI. That would be my approach for this patient.
Thank you, Praveen, for this situation. So, if I heard you correctly, you would also hesitate to put him on primary ICD right now. You will first do MRI and then decide based upon that.
Yes, sir. First, I would do cardiac MRI and then I will take, sir, based upon the scar burden and the revascularizability. Because if the RCA territory is revascularizable, it is better to first revascularize and then take for ICD.
But you know, on echo, the RCA territory actually looks fine. You think you're going to get more information on MRI?
Yes, sir.
Okay.
Most of the time, because whatever we some of the what you call even the akinetic territory with a good thickness on cardiac MRI, they were found to be non-revascularizable.
Okay, good. Thank you, Praveen. We will go ahead with our discussion. I will ask Santosh for his comment. Santosh, if you can hear me, could you please unmute yourself and share your thoughts?
Good evening, sir. Can you hear me?
Yes, we can hear you.
Sir, regarding the fluid restriction and salt restriction, especially fluid restriction, in this heat summer, it's very difficult to put an arbitrary value to ask him to take 1.5 liter or 1 liter. So I think here you should allow him to take as per his thirst, and better way to go about it is to have a weighing machine, as Prince sir said. Weight will guide him to take a fluid here, because one day the outside temperature is 44, the other day it is 34. So that's how I'll go about fluids. And if the patient has got say if the weight gain is significant on a particular day, I'll ask him to, on that day you can curtail the amount of fluid he takes. And regarding the initiation of SGLT2 inhibitors in him, so since this patient is also having a mild congestion in the form of edema and all, instead of we increasing his diuretic dose, add SGLT2 inhibitor that has got a natriuresis as well as diuretic effect. So I think this is a perfect time to start him on SGLT2 inhibitors. And regarding initiation of ARNI, so the most important side effect of ARNI as well as most important reason for the discontinuation of ARNI is hypotension. So in him, blood pressure being a 102, 103. So I'd like to start with AC inhibitors first. We'll see how he tolerates the AC inhibitors. Start him on low dose, and subsequently we can escalate every weekly. If he tolerates it well, then we can switch over to ARNI. And regarding another important thing is heart rate is 82, sir. He's already on metoprolol succinate 25 mg. So now we cannot further escalate his beta blockers because the BP is a concern. Again, we are adding AC inhibitor along with it. So in such case, I think adding ivabradine is a good choice, because we need to decrease his heart rate further to less than 70, which will be reflected in terms of better symptom improvement as well as quality of life. And other thing regarding consideration of the ICD, I think we need to put him on the 4 pillars of the heart failure treatment first. So-called OMT, optimized medical treatment, which includes ACE inhibitors or ARBs and mineralocorticoid receptor antagonists, beta blockers, plus SGLT2 inhibitors. Watch this patient for the next 3 months. Look into how this LV improves. If his LV improves more than 35%, I think we can hold on advising the ICD for him. If the LV function still remains 30%, I think he becomes a candidate for ICD. We need to discuss with the patient the risk of, whenever we are giving a ICD for a primary prevention, we should tell them the risk of inappropriate shock and device-related complication needs to be discussed in detail. I think then we have to take a call for ICD. I think that time will be a better, better after 3 months assessment will give us a better idea whether to go for ICD or not. That's how I'll go about it, sir. Thank you.
So Santosh, your question and your thoughts about ivabradine, I think point is well taken. We know ivabradine is the third line agent for our heart failure management. In these patient subset with very low ejection fraction, almost in the severe range, and who are recovering out of heart failure, how aggressive you want to be, or how early you aggressively want to reduce their heart rate, or do you want to give them some time and then attack on their heart rate? Because you understand that lot of these patients, their cardiac output is actually dependent upon their heart rate. They can't generate any more stroke volume. That is the reason why inpatient we don't target their heart rate as much as we target as an outpatient. But the question is, how long should we wait for the heart failure parameters to improve before we start targeting a heart rate of 60 to 70? I don't have an answer. I'm trying to get your opinion about how you think about it.
Yes, sir. Yes, sir. I think during the first OPD visit, that will be the better time. We can escalate the heart rate controlling agent, sir.
Perfect. Thank you, Santosh. The floor is open for discussion. If there is anybody else who has got any thoughts or who want to add in the discussion, they are welcome to unmute themselves or put their question in the chat box. And while you get your thoughts, I will address some of the things which has been brought up, and I'll share my thoughts about the point that I brought up. So if this question were to be asked to me, I would take it this way. Salt and water restriction, for me, it is the salt restriction that matters more than water restriction. And the salt restriction is independent of the outside temperature. So whether it is hot outside or whether it is cold outside, I tell patients that you restrict your salt as much as possible. A low salt burden or a low solute burden in the blood will definitely suppress the thirst mechanism in a person's body. Understanding that as the person sweats, they lose their salt, and because of that they crave to take more salt. So I am more focused on salt in these kind of scenarios, and I tell them that as far as fluid restriction is concerned, for that you simply rely upon your thirst, because if I can control the salt, then I know to a certain degree I can control their thirst. And I tell them that if few sips of water can do, then probably taking a glass doesn't need to be there. In the US, because everybody was fond of taking ice chips, it was a very routine suggestion which was there in every patient handout for heart failure, where we would tell them that switch regular water with ice. And the reason why is because ice added volume and it would stay in the mouth for a few extra seconds. So it will give them a sense that they have had enough of water as compared to taking plain water, which they can gulp within a second or two. So sometimes I say that to the patients in India as well, but I do understand that ice chips may be a luxury at some places, may not be readily available in all the households. SGLT2 inhibitors, I think I agree with you, Santosh. I would start this patient on SGLT2 inhibitor. There are concerns about dehydration, but in this patient, my assessment right now is that he is he's actually still having a little bit of extra fluid. So I'm not that worried about dehydration, although we do understand that SGLT2 inhibitors can cause ketoacidosis in the setting of dehydration, and that is something I have to be very particular about. I don't know about you guys. I start them on a low dose, and I typically start them on 5 of dapagliflozin or a 12.5 of empagliflozin. And I tend not to go at a full dose, although the studies are done on full dose. I tend not to go on the full dose. I'm still kind of waiting for more experience to accumulate amongst my colleagues before I embark upon that. In these borderline blood pressures, I don't particularly start them on ARNI early on for the fear of precipitous drop in blood pressure. I know scientifically this fear is not validated. There are at times where I started these patients on 50 milligrams of Vimeda twice daily. They go home, they get one episode of low blood pressure, they stop all heart failure medication after that. And next thing you know is they come after a month or two of follow-up saying they're not taking any heart failure medication because their blood pressure dropped. These have happened a few times with me, so I became a little bit more careful. As we were discussing with Vijay sir, that this whole rationale of giving half dose of 50 milligrams, I think that is placebo. I don't think that is scientifically validated. I don't do it. So I have more flexibility with ACE inhibitors where I can give as low dose as possible and slowly up titrate as needed. So that is what I end up doing. Although, as I said, that scientifically there is data to suggest that directly starting ARNI also does not lead to more hypotension episode than going through ACE-ARB followed by ARNI. Selecting patients for prophylactic ICD. So this point, I will just tell you about the US guidelines and what we practice in India. So in US, if we have to put, or in Europe for that matter, wherever there is standard guidelines followed, if we have to put a prophylactic ICD, then two rules have to be followed very clearly. If it is a post-MI subset, then we have to wait for at least 42 days, reassess the LV, make sure it indeed is 35% or less, then only we can advise them to take ICD. So in acute MI situation, there is a mandatory 7 weeks pause before we can put them on prophylactic ICD. For heart failure, that duration is 3 months, which means not from the onset of heart failure, but from your point of contact and from the time that you determine that this patient is on goal-directed medical therapy as much as you think the patient can tolerate. Once you reach that stage, from there, this patient needs to be monitored for 3 months. And after 3 months, you have to document whether the LV ejection fraction is still 35% or less, in which case prophylactic ICD would be recommended. And the whole idea why there is these breaks is because we don't want to put unnecessary ICDs, understanding that other than device-related complications and infection and procedure and whatnot, these are associated with inappropriate shocks, which has got medical price to pay, and also patients have psychological impact when they get these kind of shocks. So that is why these breaks are in there. I don't particularly know if there is a scar cutoff for MRI. There is some data set that 10% scar is considered significant, not in this particular patient subset, but as a general. But whether that has been a trigger point to put ICD or not, that is something I'm unaware of, and probably we can I can read more about it. CTO recanalization I have already discussed. Evabradine for heart rate control. I tend to be a little bit more conservative when I go for heart rate control. So I typically give this patient a couple of follow-ups before I start aggressively putting them on heart rate control. My biggest fear is if evabradine, particularly in acute or immediate following acute episode, if it precipitates atrial fibrillation, then that becomes another need for admission, and that creates a lot of problem. We do know that evabradine has this adverse effect profile of atrial fibrillation. So that is why I tend to be a little bit more conservative. I ask these patients to follow up a couple of times, and when they follow up, when they are doing okay, I have achieved a very stable diuretic regimen or no diuretic at all. It is then I start them on evabradine if their heart rate is still high. So I be a little bit more conservative in that regard. I believe those are all the points that were being discussed, and we can continue our discussion further. Shankar sir is here. Shankar sir, if you can hear me, you can please unmute yourself and share your thoughts. I think you got the case from the Huddle WhatsApp group. If not, then I can briefly mention the case to you. But Shankar sir, if you can hear me, please unmute yourself and share your thoughts about today's case. Shankar sir, you are still muted. You need to unmute yourself.
Good evening to all.
Yep.
I would like to I would like to hear from the experts in this regarding this case, because most of the times we come across the same problem in the scorching sun when the patients are put on diuretics, ARNI or ACE inhibitors or ARBs. along with the SGLT2 inhibitors, because now the fourth pillar being added to heart failure management is SGLT2 inhibitors, because patients they get dehydrated in this scorching sun, and this dehydration is literally it is associated with some difficulty with continuing SGLT inhibitors that we have to take care of, because the sodium and water fluid management should be better while continuing SGLT2 inhibitors, because as I told, the dehydration is definitely it is associated with the complications with the SGLT2 inhibitors. And regarding the continuation of the ARNI, recent guidelines regarding the ACCHA or ESC, the ARNI can be started even on in the heart, in the stage C heart failure. We can start straight away. Earlier, we used to give AC inhibitors or ARBs, and we give a washout period for 36 hours, and we exhibit ARNI and low dose, and gradually we build up to 200 milligrams BID. But in the stage C failure, this ARNI can be started straight away. But only thing is the economic burden will be there on the when he continues all these drugs. That is a problem with the ARNI, except it is a cost effective, it is more costlier. Otherwise, ARNI can be started from the first day onwards in the stage C heart failure, what we are confronting with. And coming to the ICD, usually there are recent indications are there, definite indications are there regarding 40 days post EMI with the LV ejection fraction less than 35 to prevent sudden cardiac death. That is ICD is indicated. But and second is even in the non-ischemic dilated cardiomyopathy also, this is the ICD is indicated to prevent sudden cardiac death. And where there is a high risk of death because of ventricular arrhythmias, if we notice, then also the ICD is indicated. So even though it is NYHA class 1, if the LV ejection fraction is less than 30% post MI, 40 days, ICD is ideal for the implantation. That is regarding the latest guidelines regarding the indications for the implantable cardioverter defibrillator. Thank you, one and all.
Thank you so much, sir. In fact, before you joined, we were discussing about this SGLT2 inhibitor in this setting where we can potentiate this dehydration-related ketoacidosis. And various attendees, they had various opinion. I shared my opinion that till the time I believe that there is any extra fluid on board, I'm not that concerned about. But I do be cautious when I start them on these drugs. So in this particular patient, I would have started, but again, I can understand the concerns of not starting as well. One question in the SGLT2 that Santosh asks is, does SGLT2 inhibitor has a class effect? Is DAPA slightly better than EMPA? Santosh, I think it does have a class effect unless we have a head-on trial. That too investigator initiated, not industry initiated. We will never know. The quantum of benefit seems to be more or less the same if you take patient factors into account in different trials. In fact, it was EMPA which was winning the race early on, until recently when DAPA HF and all those trials came, where DAPA started kind of winning the race. So I am okay with both. I am okay with either DAPA or EMPA. We end up writing DAPA because there are a lot more molecules which are cheaper available in the DAPA segment. EMPA is still a little costly. That is why we end up prescribing DAPA more frequently. The experience of vericiguat, I have not prescribed vericiguat ever. When I was practicing, when I was a trainee over there, I never, that time this molecule was not available to us. Now it is available in US, not yet available in India. I think it is being launched maybe this month. I personally do not have an experience. If any of the attendees have any experience of writing vericiguat, they can share their experience as well. Another question that comes is any role of stem cell therapy in these kind of patients? Dr. Sudhir, I don't know the answer to that question. I have zero experience on this. So if any of the attendees have got insight on that as well, we'll be happy to learn. Vericiguat and stem cell therapy. And if there is any other comments or questions which are there, we'll be happy to discuss. Okay, and if nobody has any questions, then I'll ask Somaraju sir for his opinion about this particular case and escalating heart failure therapy as a general. Somaraju sir.
Thank you, Anoop, and good evening, everybody. I just wanted to mention that one or two issues, namely the clinical trial dosage that is generally suggested need not be started straight away. They can be started at a smaller dose, and the clinical trial suggested dose can be reached progressively over a period of time, depending upon the patient's tolerance and other features. And secondly, what is suggested as optimal dosage in the trial done in the West is not the same thing as an average patient of Indian or Asian patients. So the dosages and requirements are completely different. We don't know exactly what is the right answer for it. And the other issue is I'll still go by the diuretic in a patient with heart failure and reduced ejection fraction. I still go by diuretic, S inhibitor ARB and ARNI and beta blockers. And SGL2, I don't jump as a first line preference. And lastly, I just want to point out, many of you repeatedly pointed out summer, but summer is not the same for everybody. What your patient is, what he does, what he or she is exposed to, the amount of sun, the work at work, whether he or she travels, whether the patient. Some of us are never exposed to summer, morning to evening or even night. We are aware of it, isn't it? So then similarly, depending upon what your patient is, that matters. And also, the salt restriction need not be less than 3 grams. And the best way to go by the amount of fluid and the amount of diuretic, etc. is, as Dr. Santosh already pointed out, go by daily weight in the same time. And within the 3 days, if there is increase in weight of more than 1 kg, it requires that fluid should be restricted or diuretic should be increased, etc. If there is any other question, I will be, if I am able to answer, I will answer. Thank you. Everybody, I agree with you, and you have to go slow on it, and particularly look at the left atrial size, and predisposition to atrial fibrillation is a risk unless you cannot give a beta blocker.
Sir, I have a question for you. Once a while, we encounter these patient subset who have hyponatremia. They consistently, their sodium ranges around 128, 129. Sometimes they, of course, fall down to below 125, particularly when they are sick. But no matter where you check, even in their best scenario, their sodium levels are 128, 129. To the extent that some over-enthusiastic doctor might even tell him to take salt packets twice daily. How do we manage heart failure patient who has got this chronic hyponatremia, who require diuretic, who require salt and fluid restriction, But it seems like we are countering ourselves. These patients, they may not necessarily have dilutional hyponatremia. They just have overall low sodium in their body. How do we manage? What is your trick on such patient subset?
If your first possibility is a dilutional hyponatremia of heart failure, and you should not overtreat it. And provided that is excluded, the sodium retaining medications can be started under close supervision. But that should be done under very close supervision and exceptional patient. Most of them, the hyponatremia is borderline, we should ignore it.
Sir, do you advocate putting? You did touch upon it, but I want more clarification. Do you advocate putting diuretics like loop diuretics plus drugs like tolvaptan in this kind of patient subset? Do you think we are doing more harm or we are doing benefit?
Very rare patient and occasional patient you should be willing to try. I did try, and most of the patients tolerated well, but you should be very closely monitoring.
Anybody else in the audience who has tried this combination of loop diuretic and tolvaptan to combat some of these hyponatremia features, understanding that tolvaptan also acts as a diuretic? Any thoughts, any comments from the attendees? Vijay sir, have you tried?
Absolutely, I got no idea about this this combination. And anything, hello?
Yeah, yes sir.
Hyponatremia is defined as less than 126. Suppose if the patient has got 128, we need not bother. We can ignore.
Dr. Anoop,
Yes sir.
It was pointed out in one of the previous sessions. If you have hyponatremia and if the patient's uric acid is not elevated, it is not due to the diuretic. Some other reason. Look for it carefully. Thank you.
Okay, I think that this point needs reiteration. It was brought in one of the discussion previously. I think we do need a reminder for this tip that we often forget. I often forget that if there is hyponatremia and if uric acid is not elevated, then the chances are this is not because of drug, it's because of something else. I have prescribed tolvaptan and diuretic in few occasions. I can count on my fingers how many times I have prescribed, but I have prescribed because there are situations where I get really stuck. These patients whom I do not believe they have significant dilutional hyponatremia, they are on a low dose of diuretic, something like a 5 or a 10 of torsemide. They go into heart failure the moment you stop those drugs, so they kind of are stabilized between 5 or 10. But their sodium does run at a borderline level, like somewhere like 127, 128, something like that, with 2-3 points fluctuation here and there. And at one time, their blood work will show sodium of 124, and that will panic everybody. So sometimes I back off on their diuretic, reduce their loop diuretic to half, and put them on a low dose tolvaptan just to keep their sodium level at around 130, 132. I do have, I believe, a couple of patients, maybe more, who are at the extremes of age, somewhere like 75, 80, who do develop horrible CNS symptoms when their sodium level touches around 125, 26 or so. They don't need to fall down to below 120 to develop CNS symptoms. And in those patients also, because they are obviously cardiac patients, that's why I'm seeing, sometimes I put them on a low dose diuretic and a low dose tolvaptan, something like a 15 milligrams twice daily to keep their sodium up. Whether that is scientifically validated or not, I don't know. These are out of desperations that I'm trying. The practical point here to note is tolvaptan in India is very costly. Very costly means almost 100 rupees per tablet. So I am adding a lot of financial burden to these patients. But we are looking for thoughts whether these will add any value to the patient clinical scenario or not. Praneeth, you have any comments about this?
I think to begin with, we need to correlate the number that the patient has and his symptoms. if, as you said, each and every patient is different, and if this patient is symptomatic because of hyponatremia, then probably that needs attention. Either the dose adjustment in terms of diuretic or adding tolvaptan is probably something. So I think we can't make a generalized statement on these things. I tend to ignore a lot of these low sodium values until it is less than 125 or something. Most of them are in 120s range, so I do not pay much attention to. And as I said, if he has any symptoms suggestive of hyponatremia, probably only then I would pay attention to those things and equally adjust the medicines. In my experience or in my practice, so to speak, I could not see anybody having the symptoms of hyponatremia. Most of the hyponatremia that I encountered were more in relation to usage of thiazide diuretics in relation to hypertension. That is where I had to modify, but in heart failure subsets per se, I could not recollect me needing to modify drugs to attend to hyponatremia.
Thank you, Praneeth. It is 8:01. We may wait for one more minute if anybody has got any thoughts or questions or comments about the discussion. Yes, Santosh, you are unmuted.
Regarding the resurgence of digoxin, where exactly the use of digoxin stands in this patient's context, sir, now?
Okay, I think that now you probably are initiating a fight amongst a lot of cardiologists. So I'll tell you my version, and I'll let my colleagues and attendees talk about their version. In my opinion, unless there is atrial fibrillation, none of my patients are on digoxin for heart failure. Earlier, the discussion was whether digoxin will reduce the incidence of heart failure hospitalization. That data is kind of iffy when you look at certain data set. In fact, there are certain newer data set which talks about digoxin may be helpful. But as a general, I do not prescribe digoxin in a patient who has a pure heart failure subset unless they have atrial fibrillation where I need to control their heart rate. I invite thought process of other colleagues, maybe Vijay sir, Somaraju sir, about what their thought would be for digoxin.
Digoxin is only my choice when the patient has got AF. If the patient is in sinus rhythm, I don't recommend it for heart failure.
Somaraju sir, the role of digoxin in the modern clinical practice of heart failure.
You have to go by clinical evidence, evidence from the trials. There is no indication in this subsets of patients. You already mentioned atrial fibrillation. That's a different issue. And having said that, one must be aware that patient whose ejection fractions are around 30s or less, and we are worried about ventricular arrhythmia, sudden cardiac death. The threshold for ventricular tachycardia and fibrillation are brought down by digitalis. It need not be digitoxicity. Even just digitalis exposure can do that, though proof is difficult. There are case reports and some evidence to show that serum digoxin levels don't help in this situation. It's better to avoid because it doesn't greatly help.
Thank you, sir. Santosh, I think I have one patient who is on digoxin for heart failure. I am not proud of that because of even that one patient. But I'll tell you the subset on which that patient continues on digoxin. This is the guy who has got bad heart, and literally I am not able to give him any other medication, and he's not a transplant candidate. So this is out of desperation. This patient's longevity is anyway very low. I think I'm taking care of this patient for the past 1 year or so, and I may have seen him twice so far. So this patient is on digoxin. I inherited this patient on digoxin. I typically stop digoxin when I see it is being given for heart failure. In this particular patient, I did not stop because I didn't have any other option to offer to him. So that is, I believe, the only patient who I have who is taking digoxin for heart failure.
Thank you, sir.
Okay, if there are no more comments, I'll ask Praneeth for his closing comments for today's discussion.
Yeah, no. Heart failure is something which is pandemic, and we all deal with heart failure. And I believe everybody buys the idea of giving the guideline-directed medical therapy, but there are challenges, particularly when we take practical considerations. The discussion on the local factors, particularly the weather conditions, which interferes with you to give the so-called guideline-directed medical therapy, and just blanket statements probably won't help. Spending time with the patients, knowing the patient's conditions, particularly as Somaju sir was suggesting about the weather conditions may not be the same for everybody. How much is that weather conditions or any other practical considerations are affecting an individual patient? Maybe we'll be able to better appreciate only after we sit with the patient, involve with him, take a detailed history, understand his conditions better, and probably modify these things appropriately. And I believe as a physicians, it is a responsibility to take into consideration everything when we recommend. At least in India, I believe that patients do take the recommendation seriously. So recommending ARNI or recommending ICDs, which are a bit costly affairs. So these things we need to see patient in general as how much the added value are these therapies going to offer to the existing therapies, which may be a cheaper alternatives. And as I said, each and every patient needs to be individualized, and these therapies should be given as much as possible. The guided directed medical therapy should be given, provided his needs are there and we ensure the compliance is achieved. And I think very valid points in relation to Ivabrad and Digoxin, which are again commonly used, have been brought up in this discussion. Thank you, Anoop.
Thank you, Praneeth. I request if anybody has got any reading material or anything that they can share regarding Vericiguat. It's a new drug. It will be soon launched in Indian market. I think this is something we can read about and increase our knowledge base. Same thing goes for stem cell therapy. If there is any data about it, maybe you can help sharing that data on the WhatsApp group so that we can read a little bit about that as well. With that, I will close the session for today. Thank you all for participation. We will meet again next Wednesday with a new topic. Thank you all. Good night.
Dr. Anoop, can you
Yes,
hear
sir.
me?
Yes, sir.
Two things I just want to point out.
Yes,
One
sir.
is when you have to start any of these medications, some of the medications, the patients have to be seen frequently, and the heart failure clinic or your personally, whomever we are looking after the patients on a personal basis, the type of the charges should be liberalized in such a way that they don't pay every visit or every week or every 2 weeks or 3 weeks. So that's one component wherever we work, and so that they can afford it. And they are not discouraged to come back to us and see us, because initial days they need to see us more frequently. And second is, most of you talked about summer. I think summer affected some of us more than the patient's heart failure, because this is one of the Huddle sessions which the least number of people are attending. I think it affects cardiologists and physicians more than patients. Thank you.
Thank you so much, sir. The points that you mentioned are well taken. In fact, it does make me think, and I have thought over it multiple times, that just like diabetes patients, a lot of you are aware that many hospitals, they do a diabetes 360 program where patients kind of get an annual membership. And that annual membership comprises of these many follow-ups, these many investigations, concierge service where they can call a nurse or nurse can call them and whatnot. So it kind of is beneficial for both the patient as well as for the hospital, because hospital of course makes money out of the subscription fee, but it benefits patients more because now they are far more engaged in the therapy, and because they have already paid for it, they don't shy away from taking those benefits. So I often wonder that these patients who have got a documented heart failure with reduced ejection fraction, if we can come up with some kind of program for them where they pay a one-time fee which shouldn't be very high, truly speaking, and we give them a comprehensive assessment for a year where they have got frequent visits, sometimes with the nurses, sometimes with the cardiologist, and we give them all the teaching, education, basic lab work, and all those kind of things. I think something like this is the need of the hour, where rather than charging a patient full price every single time they come, we kind of give them a package, as to speak, or an annual membership, like a gym membership or something of that sort. I believe that maybe a few leaders amongst us, they can initiate that in their hospital, and people like us can follow once a program like this is set in practice. With this, I end the session. It's 8:10, and we hope that the summer won't affect cardiologists more, or doctors more, than what it is doing right now. And in the coming sessions, we'll have a slightly better attendance. Thank you. What Dr. Somaraju said, even if there is one person attending, we will continue doing this till we have got juice left. So thank you all. Good night, and we'll see you again next Wednesday. Take care.